Next talk is Total Intravenous Anaesthesia and Current Day Practice by Dr. G D Puri, who is the professor in the Department of Anesthesia and Intensive Care in PGI Chandigarh.
Good morning. First of all, thanks Dr. Bala for inviting me here. It's after a long time I'm coming to this part of the country and meeting my old students and colleagues. Well, when he gave me a topic of total intravenous anesthesia, maybe because I have some interest in pharmacokinetics, but I thought, I hope he's not considering me as a mathematician or a pharmacologist. My disclosure are that is no industry sport. We have a patent on closed loop anesthesia delivery system CLADS in the US as well as in India. And my aim will be to tell you people some basics of PK modeling for controlling TIVA, which you call total intravenous anesthesia. Some practical aspects of drug dosaging, instead of being blind 2 milligram per kg or 1 milligram per kg for 3 milligram per kg, some the rationale for why you give this milligram per kg of body weight, if I am able to teach you in the next couple of minutes. What's the current status of TIVA, especially different super specialties, role of automation in TIVA. Before, I just want to know how many of you how many of you use total intravenous anesthesia classically or non-classically in your setup. How many are? You may not give 10 seconds, you can give 5 seconds because there's no thinking involved in this, just from my assessment. So, well, most of you use in less than 20% of your cases. And how many of you use nitrous oxide? How many cases do you use nitrous oxide? So, most of you use nitrous oxide. And how many use target control infusion while using propofol? Well, so that gives me a reason for taking this lecture, Okay. So history is very important. What was only conceivable yesterday is achievable today, and see, we shouldn't forget this picture and the date and the place where we started around 2 centuries ago. I hope all of you know this place in Mass General Hospital. Whether it was 2 centuries ago or whether today, the aim of anesthesia is to make sure that you facilitate the surgery without causing pain, movement, awareness, any harm to the patient. And the aim is, as soon as possible, patient is put to sleep, good analgesia, and good recovery. It's an art or science, I don't know, but when you practice it over many years, even if you don't know the science, you become the artist, and you're able to give a good technique to your patient or to anybody, whether you are a artist in the gallery or you're the artist in the OR. We started with inhalation anesthetic agents many years ago, and the usual way of controlling was the subjectivity of, which had the scientific basis, pupil, heart rate, blood pressure, movement. Then with the development of thiopentone, IV anesthetic agents, started using them to induce the patients, and then when we got this short-acting safe anesthetics like propofol in the 70s, we started using them as, for a long period of time, prolonged infusion without causing much problem. Most of the times we still believed in adjusting blood pressure, heart rate, movement, and based on some basic principles of MAC or CP50 in case of intravenous anesthesia, without knowing that this only refers to the 50% of the patients. What about those patients who are below this line? You are over-anesthetizing them, and these we are under-anesthetizing them. So that's the reason you always used heart rate, blood pressure, etc., to titrate up and down. And maybe with the use of antidal concentrations of isoflurane or halothane, whatever is available, you were able to adjust them better. And with the development of the muscle relaxant and balanced anesthesia, which you give 3 different drugs to achieve 3 different components of anesthesia, things became more complicated, especially when they interact with each other like analgesia and the hypnotic agents. So we had the way to monitor each one of them, but then that's add headache to the patient, to the anesthetist. And more so when patient's heart rate and blood pressure does not respond to the pain, etc., because he's on drugs, which depress that, or there's altered pharmacokinetics which may result in different plasma concentration for the same amount of drug given in 2 different patients. And then the 2 different patients may respond differently because of pharmacodynamic effects difference. So we have huge number of parameters coming on our monitors, including, anesthetic agent concentration, heart rate, and another thing which is added is the bispectral index or any other entropy or any other anesthetic depth monitor. And that's why we are able to do total interventional anesthesia, where we cannot even measure the concentration. As far as today is concerned, maybe a couple of years down the line, we may be able to measure the antidal concentration of propofol also, because it's an aromatic compound and people are working on that. And the reason why the total interventional anesthesia is propagated is this causes less nausea, vomiting. You can, if you have TCI, you can titrate it. It's good for the neurosurgery patients. And what I use it more is because it avoids pollution in my environment. And because I am working in cardiothoracic, so I am worried about hypoxic pulmonary vasoconstriction, and that's why I like this. There are specific indications that TIVA has a huge list of this, which is available here and in the books. Some are common reasons for justifying, some are special reasons for giving. I give another reason here, the difficult intubation. This is one of the patients of difficult intubation cardiac OT, where we had to put TIVA using clads, and it took us about half an hour when we were struggling from here to this to put in a tube. But all this time, everything was stable because the machine or the TCI, our indigenous, was working well, controlling. We didn't have to bother about the ventilation. Well, we were ventilating with other ways, but at least inhalation anesthetic agents going in and out was not a concern. So how to model your drug delivery based on the existing knowledge and the literature? So the mathematical modeling is a very sophisticated term, but it's very simple. PK is about the relation between the concentration of the drug in the body following a given dose, and PD is the effect of a given drug concentration on the end organ where we are interested in. It's not a very difficult. It's a very difficult word to understand, but practically it's not very difficult. There are steps to learn, but if you know some basics, you will be able to practice well. I'll try to explain it from a case studies. We did PK analysis of propofol in Indian patients, healthy individual, 26 selective patients. We gave 2 milligram per kg of propofol and measured plasma concentration over a period of next half a day or 24 hours. One concentration was measured in 24 hours, but we didn't find any plasma propofol concentration in that. And see, this is the average concentration at different time points. And if you put it on the log scale, what we find is there are 3 different curves. One, this sharp, the faster, slower, this is the slower, and that's the elimination phase. So the 3-compartment model is that when you inject a drug, you produce into the initial, it gets diluted with the initial volume of distribution, which not exactly plasma volume, but little more than that, including the volume of some of the major organs. So I'll be discussing about this later. So it dilutes with that to produce the plasma concentration, which gets equilibrated over a period of time with the effect side. But at the same time, it is equilibrating with the fast compartment. And that is the drug concentration is decreasing from here, going to this based on this rate constants. There's the faster distribution compartment. And then as you keep infusing the drug for longer period of time, it starts concentrating here also, even the vessel poor rich group. While at all the times it has been excreting at the fixed rate of metabolism or excretion, whatever you may call in a particular drug, in this case of propofol, it's metabolism. So this is the fixed rate, and this is the variable rate depending on the time. So if you keep giving for long period of time, then you land into problem of context-sensitive half-life. So because of this, compartment gets equilibrated, and even if you stop infusing drug, there is a limit to which it can be eliminated. But while especially the drug is not injected from outside, but is being injected from the slow compartment into the center compartment. So that's why you say as longer the infusion, the longer is the context-sensitive half-life, and that creates problems, especially with the drugs which have 3-compartment model. But those who have only 1-compartment model, who are mainly confined to the plasma and they get excreted or metabolized, there whatever is the elimination half-life is actually there, the context-sensitive half-life. So coming back to our case study, we used mathematical calculations using vinolin, and we tried to find out the various rate constant in our population, initial volume of distribution, etc. And what we found was our center compartment initial volume of distribution was about 13 liters in the average 60 kg adults, and the clearance was 1 liter per minute. And we compared with the existing single dose studies in the literature. Our volume of distribution was slightly more than the rest of the studies, and the clearance was also less than the other studies. Well, the March model, which is existent since 90s, has been based on has been adopted from the GAPS 3-compartment model, and we compared our data with that. Was quite similar. The initial volume of distribution was 0.21 liter per kg as compared to 0.23 liter per kg in Marsh model. So, just touching about some other models which are available, don't get confused. They are once you understand the initial basic things of these models are just the different numbers you put into the computer to find out the rate of infusion. So the Schneider model which was developed, it added more covariates in addition to the weight, which was the only variable in the Marsh model, and what we found also in the normal healthy adults. So, but the issue with Schneider, the Marsh versus the Schneider model is that the Marsh gives the initial volume of distribution, which is weight dependent, while the Schneider gives us fixed weight of volume. So there are, and it weights basis on the lean body mass, which has problems of calculation. The lean body mass, as you say, as the total body weight increases, the lean body decreases. I am referring to another model, which is the Kataria model. He happens to be my class fellow when I was doing my graduation way back in 70s. Dr. Kataria, maybe we were similar, interest. So we continued with our interest, PK interest. He developed this children model. So based on this initial model, we thought, okay, let's infuse our patients with this model and find out whether we are able to achieve the plasma concentration. So what we gave the loading dose, we gave the after that decreasing rate of infusion based on this equation, and took the samples. We used the computer whom we interface with the syringe pumps, and we can set what model we want to give and what concentration I want to keep, and then it calculates the dosage and keeps giving that. And what we found was what was targeted was almost same was Mayed, and we found the performance error, which is the Mayed versus minus predicted over the predicted concentration, and we didn't find much difference. So the performance was only 2%. And when we studied the literature, the other models which have been studied had wide variation. So what we made was good for our patients. We tried to replicate the same in the cardiac surgery patients. Well, cardiac surgery patients, because of bypass, the hemodilution, hypothermia, varying cardiac load, etc., The stability was not that great, but still, because this is the bypass period when it just the concentration initially drops and then rises, the performance are also very comparable when we use Marsh model or our PGI model. So, in nutshell, we can use this in the different conditions practically fairly good. We studied at the high altitude. We went to Leh. We studied patients there. We found that propofol requirements were higher there, and the people recover from that very fast as compared to lowlanders. And we thought, let's do some PK study. The preliminary data shows that they have initial volume of distribution was higher there, but the excretion was slower. So what does it mean? We are still completing more cases. And if you see that Highlanders, the initial volume of distribution is more, so they achieve lesser concentration initially, but later on the decrease in concentration is slower, but they recover faster. They recover at a higher plasma concentration, even 2 microgram per ml concentration they recover. Their initial volume, this is what they found. Then we studied in children. What we found in children was they have significantly high volume of center compartment and slightly higher systemic clearance, and that's the reason they require higher dosages to give, maybe 2 to 3 times the dosages. So our adult was 211 ml per kg, while the children it was about 600 ml per kg, which is comparable to Kataria model. So with this variability of PK, organ dysfunction, etc., can we still think of targeting a concentration and achieving it, and then maybe? Then here is one thing which can help when you're using total intravenous anesthesia and are not having any anti-idle concentration monitor. The anesthetic depth monitor can be of use. But even if you have to titrate to anesthetic depth monitor, you must have some knowledge of what should I give, what target concentration should I achieve. So we did another study and we found that the relation between the BIS and the target concentration. We found that to achieve loss of consciousness, about 3 EC95 was 3 microgram per ml to produce anesthesia that is non-responsive to pain. We need about 5 microgram per ml, and this is little lower than what was the Chinese or the Caucasian studies had shown. So once we know what concentration to be maintained and how to maintain, then should we do manually or should we do using computers? So this is the technique BET scheme, where we say initially load the compartment, the bolus, and then compensate later on for elimination as well as redistribution. So that's what we do. And it was a good formula suggested. Most of the people use 2 milligram per kg body weight to induce patients with propofol. I don't know why. When we know the 0.2 liter per kg is the volume of distribution, and if you can achieve sleepness with the 3 microgram per ml, with the anesthesia with 5 microgram ml, why we give 2 milligram per kg body weight? We just need 1 milligram per kg body weight. That's what is. But normally we never infuse the drug after we give the initial bolus. So what is needed is give 1 milligram per kg, then start infusing at 10 milligram per kg for 10 minutes, then 8 milligram per kg for 10 minutes, then later on for 6 milligram per kg. This is a good practical way of achieving. For pediatric manual infusion regimes are a little different, and this is what, if you calculate it, it comes to almost about 2 and 2.5 times what we have suggested. So the drawbacks of this is the same as I said earlier, the variation between the patients, both for kinetics as well as dynamics. And now, manual versus automated drug delivery, that's another thing which people will say, that I don't have computer, I don't have the TCI. But way back in 90s, Glenn as well as Kenny, they made a lot of money from this simple formula. They incorporated the formula into syringe pumps, and they made this syringe pump was 10 times the cost of the simple syringe pumps at that. And to avoid this, nobody can take another drug, what they did, they used this specific syringes. We had a chip here so that this pump will only recognize that syringe. And once the syringe is empty, the chip will get deactivated, so you cannot reuse the syringe. So they made a lot of money. Now we have the open TCI systems in the market where you can have the pumps have the program in their chip to adjust to the different the models. So we use our simple computer interface to our syringe pumps, and we control, as I told earlier, in our TCI studies. And it can display the concentration, the expected concentration of the plasma. This is the rate of flow. Initially, that we give a bolus and then slowly keeps decreasing. If you, from target of about the plasma concentration of about 3, then we shift it to 2.5 and 2, and that's why the rate of infusion starts decreasing. So, which is better? Well, it all depends what you have and what you have in your pocket and what you have in your brain. But the studies have shown that the manual control and TCI are comparable. Some studies have shown this better TCI. The Cochrane analysis says there's all equal. Probably they are intelligent anesthetists who are working in the manual. What another concept I want to bring it here is the effect site. I'm confusing a little more. Whatever is developed in the plasma concentration is not what develops in the effect site. It takes time for it to equilibrate, and that's the reason when you give a concentration of 3, this is the effect site concentration. It takes a couple of minutes to build up, and when you build again increase to 6 microgram plasma concentration, it takes time to build up. So that's the reason, though to make the person sleep, you only give 3 microgram, you need only 3 microgram per ml in the body, which means you only have to give 0.6 milligram per kg of propofol dose, but you give 5 to, almost double the dose, 1 milligram to 2 milligram per kg. Basically, what you try to do is, you oversaturate the plasma so that the effect site concentration builds up quickly. So here, if you produce 7 microgram per kg, microgram per ml in the blood, you will be able to achieve your effect site concentration quickly. So if you have to achieve a higher concentration, you have to plasma concentration have to be achieved much higher. The good is that you will produce a quick effect, but the bad thing is, unfortunately, the heart comes before the brain. So whatever concentration you are giving to the plasma first goes to the heart and will produce cardiovascular disturbances. And that's the reason people say, propofol is not a very good drug. I say, if you use it properly, it's a very good drug. Only thing is, if you use the way people used to think, that may not be. Then you may produce problems. So the best thing is, achieve 5 microgram per ml in the blood and maintain it with the infusion simultaneously, rather than giving a single bolus to produce 10 microgram per ml in the blood. So the advantage of the, in addition, can I take another 5 minutes? Bala? 2 minutes, okay. So quickly running this thing, and what I'll just try to spend a couple of minutes on once we interface the computer with the syringe pumps and then with the BIS monitor and things, you can, and put simple algorithm, you can control the delivery based on the feedback. Need not have to waste time on looking at the BIS monitor, and that's what we have developed, the closed loop anesthesia delivery system, the future of anesthesia. And you can control the muscle relaxants, you can control the narcotics, you can control the hypnotics, and it reduces the workload of the busy at the busy time and the expert eye and brain 24 hours, because the algorithm is based on the book knowledge which is available to all the residents 24 hours. You can control all these drugs during this. Anesthesia is complex, automation is the need of the hour, 80% of the errors are because of human, and you can't give your anesthesia blindly, the way this fellow is driving the boat. And we published a study 10 years ago on the initial performance assessment, and number of studies subsequently used in different conditions like pheochromocytoma at high altitude, in cardiac surgery, and even pediatric surgery, and multicentric at 6 different centers in the country. What we found was it reduces the consumption, it produces much stable, this is the BIS values, much stable BIS values as compared to much wider BIS values in the manual group, and most of it can help the anesthetist to take care of other things rather than just controlling the propofol and relaxant. So every breath you take will be watching you. That was the editorial in anesthesiology 10 years ago, where they had published the initial studies showing the monitoring of propofol and end-tidal, and maybe in another 10 years down the line, we may have this concentration monitor, and then our closed-loop system will maybe much better controlled than what we are doing at the moment. So as far as the pediatrics is concerned, just to tell that though we claim the PONV is less with total intravenous anesthesia in adults, but it has not been proved to pediatric. Dr. Ramesh may endorse my views here. And the pain injection, acidosis, etc., need of IV exercise is other reason why we do not practice for induction of the intravenous anesthesia, but maybe we can continue the maintenance. Liver transplant, though the propofol is metabolized in the liver, still it is been used as a liver transplant. Only thing is, during anapatic phase, the 40% reduction in the propofol delivery needs to be done because the absence of the liver during that period. Neurosurgery, raised ICP, we know. Laparoscopy also has been shown to be better. TIVA has been shown to be better than inhalation anesthesia. Bariatric surgery, I just want to touch one point here. Now, it has been shown to reduce risk, but the problem is what weight you use to your drug, the patient. Total body weight, lean body weight, idle body weight, fat weight. And the problem with this lean body weight is as the total body weight increases, the lean body weight start decreasing. And here you will find the lean body weight has become less than 20 kg. So there's the problem with the formula. So what they say is we use only where the lean body mass is maximum for a given weight. If it's 140 kg and is falling on this line, don't go beyond this. Use this as the lean body weight and use it. So this is the general formula that for induction you use lean body weight, for maintenance you use total body weight, for controlling anesthetic agents, and for the relaxants you always use the ideal body weight. So I'll skip that. We already know the nitroxide is still being used by a lot of people as by the question. I thought things might have changed in the last 10 years. This was the query, the Indian Journal of Anesthesia published paper. So still we use in my OR, in the cardiac center, we don't have the nitrous pipelines. We have never used nitroside for last more than 10 years. Well, analgesics is another combination of TIVA. I didn't touch it, lack of time. But what especially I just want to allude this slide is that when you are using remifentanil, anybody using remifentanil in the here? I don't know whether some people bring from outside and use, but that the problem with the remifentanil, as you know, is that it's very potent. The good part is it's good recovery, shorter half-life, and minutes you stop, the patient will recover from that. The problem is the postoperatively will have pain. So if you give high remifentanil intraoperatively, then it has been shown that patient may have more pain postoperatively, not because you have not given analgesic intraoperatively, but because you have given too potent analgesic intraoperatively. Then does the TIVA with propofol has postoperative pain requirement decrease? Yes, it has been shown that if the patients are given propofol anesthesia during surgery, postoperatively their pain analgesic requirement is less. So I hope I have been able to make people understand why and how much of propofol or the anesthetic drugs you should need to be giving, how you need to control your plasma concentration, and how the combination narcotic and hypnotic can be used to decrease the anesthetic requirement, and how anesthetic depth monitors can help in titrating the anesthetic dosages. It's not what to give, but how you give is more important. Thank you very much. Sorry.